Introducing the Pleur-Evac Dry Suction A6000 Chest Drainage Series. Setting up the Pleur-Evac A6000 series is a three-step process. The first step is to establish the water seal. Fill the water seal chamber through the suction port using the enclosed pre-measured bottle. The water seal unit will fill to the 2 centimeter level. Second, using the patient connector attached to the 6-foot patient tube, connect the tube from the collection chamber to the patient's thoracic catheter. The patient now has the protection of the water seal. The water seal serves 3 purposes. Due to its U-tube design, it acts as a one-way valve, allowing the evacuation of air from the patient's chest cavity, but preventing its re-entry under normal conditions. It serves as a measuring device for monitoring patient negativity, which is the negative pressure in the patient's pleural space. The third purpose is to monitor patient air leaks via the patient air leak meter. The third step in setting up the Pleur-Evac A6000 series is selecting the level of imposed suction, if suction is prescribed. This is the suction control chamber. With the Pleur-Evac A6000 series, no water is required to operate suction control. A dial for setting the desired suction level is on the face of the unit. To set the level of imposed suction, turn the suction dial to the prescribed suction level. 5 settings are available: -10, -15, -20, -30, and -40 centimeters. The dial clicks at each suction level. The dial is preset at -20 centimeters of water. Next, connect the short suction tube to the suction port and adjust the source suction until the fluorescent orange float appears in the suction indicator window. This is visual confirmation that the set level of suction is being maintained. Once chest drainage has begun, the unique suction regulator controls the amount of suction on the patient's pleural space, even if source suction or patient air leak fluctuates. No adjustment is necessary as long as the orange float remains in the suction indicator window. When suction is not being used, keeping the suction tube uncapped and unclamped is recommended. This allows air to exit freely from the patient. Patient negativity can be determined by adding the level of imposed suction selected on the suction dial to the number corresponding with the water level in the water seal, if elevated. For example, 20 centimeters of water in the suction chamber is added to 5 centimeters of water in the water seal chamber. This equals 25 centimeters of water, or the total amount of negative pressure in the patient's chest cavity. There are instances when a patient will develop a high level of negative pressure. This may occur with respiratory distress, coughing, crying, or other factors such as stripping the chest tubes. When negativity increases, the water will rise in the water seal. If the water rises beyond the -20 centimeters level, the white float ball rises, impeding the flow of water. Although water will rise beyond the valve, there is a high negativity relief chamber above the valve to contain the water. Regardless of how high the patient negativity rises, water will not spill over into the collection chamber. This unique relief chamber allows the patient to develop negative pressure as high as needed for inspiration. However, in instances of unintentionally imposed high negative pressure, water will continue to rise, filling the high negativity relief chamber, which will automatically vent excessive negative pressure. Suction level settings can be changed anytime. To increase the suction level, turn the suction control dial and observe the stripe indicating the desired suction level setting. Lowering imposed suction is a 2-step process. First, turn the dial to the lower suction level desired. The water in the water seal will rise, indicating the patient's negative pressure is still at the originally imposed level, unless the patient has an air leak. Second, depress the high negativity relief valve while observing the water level in the water seal chamber drop. By depressing the valve, filtered air enters the unit. Now the patient negativity is at the new lower level set on the suction control dial. With suction, the high negativity relief valve can be used at any time to manually vent excessive negativity. On the top of the unit, at the top of the water seal, is the positive pressure relief valve. If suction tubing is blocked or occluded in any way, this valve provides a channel for air to exit from the Pleur-Evac unit, preventing a tension pneumothorax. Any positive pressure that bubbles through the water seal, not drawn off through the suction tubing, will be released through this valve. Patency of the tubing may be observed as the tidling of water in the water seal chamber. On the front of the water seal chamber is a self-sealing diaphragm for adding or withdrawing fluid. Use a 1 1/2 inch 18 gauge or smaller needle attached to a syringe. Angle the needle downward. Fluid may need to be withdrawn if the water seal is accidentally overfilled, or added if fluid in the water seal chamber evaporates. Evaporation may occur in the presence of a large patient air leak. If there is an air leak, bubbling will appear in the patented patient air leak meter. The meter is calibrated from 1 to 7. Chart the column farthest to the left, in which the column of bubbles appears. By observing which column is bubbling, it can be determined whether the air leak is increasing, decreasing, or constant. At the junction where the 6-foot patient tube connects to the collection chamber, anti-kink tubing is provided as a standard feature. On adult pediatric units, the patient tube also contains a needleless sampling port, allowing fresh specimens of patient drainage to be taken whenever needed. A standard Lure-Lock syringe may be used for this purpose. The collection chamber on the adult pediatric Pleur-Evac A6000 unit consists of 4 interconnected columns with a total capacity of approximately 2,500 cc's. The first column measures in fine increments of 1 cc from 0 to 100 cc's. From 100 cc's to 200 cc's, increments are 2 cc's, and then 5 cc's for the remainder of the collection chamber. Fluids fill the first column and then spill over into the second. After the second column fills, the fluid spills over to the third, and subsequently to the fourth. The white measuring stripes can be used to record the amount of patient drainage. All blood has potential value. That's why all adult pediatric Pleur-Evac systems have a post-operative auto-transfusion option, which allows an auto-transfusion bag to be attached at any time. The Pleur-Evac A6050 ATS has the auto-transfusion system already attached. The process involves 3 stages, and they are the same for post-operative and post-traumatic chest drainage. These stages include setup, collection, and reinfusion. Refer to the current standard of the American Association of Blood Banks for auto-transfusion. Using appropriate technique to maintain sterility, make sure all clamps are open and all connections are tight. Follow hospital policy regarding use of protective wear when the possibility exists for exposure to blood or body fluids. Once the unit is set up, collection into the bag is automatic. Drainage is filtered by a 200-micron double-sided mesh filter. The collection bag has a capacity of approximately 800 cc's at minus 20 centimeters of water and 1,400 cc's on gravity drainage and is marked in 20 cc increments. Time and amount of drainage can be noted directly on the bag. When ready to remove the bag, if collection is to be continued, a Pleur-Evac A1500 replacement bag should be obtained and opened using appropriate technique. Next, the 2 clamps on top of the bag should be closed to maintain a closed system during replacement. Prior to removing the first bag, excessive negativity should be reduced in the system by depressing the high negativity relief valve. This will facilitate removal of the collection bag from the support stand. Next, close the clamp on the chest drainage tubing. Connect the replacement bag to the Pleur-Evac unit using the blue connector. Then connect the patient chest drainage tube to the new bag using the red connector. After checking to ensure that all connections are airtight, open all clamps on the replacement bag and drainage tube. The auto-transfusion system is once again collecting patient drainage. Before removing the original auto-transfusion bag from the Pleur-Evac, connect the red and blue connectors on top of the bag. The next step is to remove the original bag by lifting it so the wire frame slides off the side hook. Then, disconnect the bag from the foot hook on the Pleur-Evac unit. To secure the new replacement bag, connect the foot hook and replace the wire frame into the hook on the side of the Pleur-Evac. Push down to secure the frame onto the hook. Removing the bag from the frame can be done by placing the thumbs on top of the metal frame and exerting upward pressure with the fingers to slide the bag out. To prepare for reinfusion, invert the collection bag so the spike port points upward and remove the protective cap. When reinfusing, use of a microaggregate blood filter is recommended. A new filter should be used with every auto-transfusion bag. Insert the microaggregate filter into the spike port using a constant twisting motion. While keeping the unit inverted, gently squeeze the auto-transfusion bag, pushing the air ahead of the blood and slowly priming the filter with blood. Invert the collection bag and continue to prime the filter, drip chamber, and IV tubing before closing the clamp on the reinfusion line. Hang the bag from the IV pole. Open the clamp and carefully flush the line to remove any remaining air prior to reinfusing. Gravity, a pressure cuff, or an IV pump can be used for reinfusing. Anticoagulants may be added at the physician's discretion. They may be added to the auto-transfusion bag using the self-sealing port on the auto-transfusion connectors using a standard Luer-Lock syringe. If auto-transfusion is to be discontinued, the patient's chest drainage tube should be attached directly to the Pleur-Evac A6050 ATS by connecting the blue and red connectors. The clamp on the patient tube should then be opened, and all drainage will be collected directly in the Pleur-Evac unit, which must later be discarded. Each chest drainage system in the Pleur-Evac A6000 series is precisely designed to meet the specific set of post-operative or post-traumatic needs. In addition to the A6000 and A6050 ATS, we offer the Pleur-Evac A6002 and A6020 chest drainage systems. The adult pediatric A6002 is a double collection chamber unit. An auto-transfusion bag may be added. 2 patient tubes are provided for drainage into 2 separate collection chambers. The minor collection chamber has a capacity of 950 cc's, while the major collection chamber has a capacity of 1900 cc's. The water seal and dry suction control chambers are identical to the other adult pediatric units in the Pleur-Evac A6000 series. The auto-transfusion connector is in the patient tube that connects to the minor collection chamber. All dual-chamber Pleur-Evac units can be converted into a single-chamber unit by using a PE105 occlusion plug. The Pleur-Evac A6020 is designed for use with infants. Its collection chamber has a capacity of 150 cc's with very fine half cc increments for the first 10 cc's. A self-sealing diaphragm is in the back of the collection chamber for taking patient drainage samples. The smaller tubing and connector are designed especially for patient safety and comfort, and more secure connection to smaller-sized chest tubes. The maximum suction setting for this model is minus 30 centimeters of water. The Pleur-Evac A6000 series provides unmatched diagnostic capabilities, reliable patient safety, and maximum precision, affording the user the utmost in convenience and confidence. The Pleur-Evac A6000 Chest Drainage Series, another breakthrough that reflects our commitment to attaining unprecedented levels of patient care. For information about the Pleur-Evac A6000 series, please contact your local Teleflex medical surgical specialist.